My journey in medicine, I actually studied in India. I studied in Manipal, and then after that, I came back to Malaysia. I worked as a medical officer. Actually, surgery wasn't my first choice. I actually thought I'd be a physician, but by default, I was in the surgical posting in Malaysia, East Malaysia, and it grew on me. And so I did surgery and in Malaysia, and then I did colorectal surgery as well. And then I went to spend a year in the US in California for colorectal surgery. And then I moved. I came back. I went to Australia for a few months, and I was in France to do a bit of laparoscopic surgery. I came back. I was the head of surgery for state Negeri Sembilan in Malaysia. And then I left to private practice, and so now I'm in private practice in Colorectal Clinic Associates, Gleneagles, in Kuala Lumpur, and yeah, that's been my journey. First descriptions of laparoscopic colectomy or assisted colectomy was in 1991. And since then, it's almost become the in thing for us as colorectal surgeons to do now. We know that it is the preferred method both for benign diseases and malignant diseases. Compared to traditional, the scars are smaller, the recovery is faster, there's less blood loss, the cost may be slightly more, but shorter length of stay, so the cost comes down to that. Oh, my mic is falling down. And there's reduced morbidity and mortality. We know that studies like the COST trial, the Color 1, the Color 2 trial from Europe, and then the Classic trial from UK, all these studies have shown that laparoscopic or minimally invasive surgery in colorectal resections have a benefit. And then they also studied what about the oncologically compared to open and laparoscopic, and they realized that with this lymph node and then clearance, TME, total miscellaneous excision, in all of these, the laparoscopic is equal to open surgery. So, and notwithstanding the fact that, when we do laparoscopy, the camera actually enhances our view by about 30% compared with our naked eye. So, minimally invasive surgery, laparoscopic surgery, robotics surgery, all these are now the standard of care. There's two different thoughts on this. When I started with right-sided colon. I found that easy. I put 4 ports, one in the umbilicus, 2 on the left hypochondrium, and 1 the suprapubic, and I managed to do that. I always thought that, but I know from talking to my colleagues in the US, some of them like sigmoid lesions as well. So either the right-sided fecal lesion or a sigmoid lesion will give us kind of the early, how do you triangulate and how do you move the bowel and look for the vascular structure or the ureter on the left side to do surgery safely. So I think either one is good. For me personally, I think the right is easier, but different trainers have said even the sigmoid lesion does just as well. So Iras, as you probably know, Professor Khaled was the one who came up with this idea, and he actually came up for open surgery, not even laparoscopic. And so when it came to laparoscopic surgery, it just made it much better. Now, what we do is there's a preoperative, there's an operative, and a post-operative phase. Now, in the preoperative phase, I think the first one is counseling the patient what to expect in surgery, what to expect after surgery, and the recovery process. So they're already preempted of what's going to happen. Then we don't fast them too long. We give them fluids up to 2 hours before surgery. We give them carbohydrate loading. Bowel prep, well, there's selective bowel prep, especially if we do left-sided surgery, antibiotic prophylaxis, DVT prophylaxis. And then we try not to use too much of pre-med. Now, intraoperatively, we try to encourage our normal thermic, which means keep the patients in not in high, because OTs can be cold, so normal thermic. We tell our anesthetists not to give too much fluids or salts because sometimes the bowels get edematous if there's too much fluids. Epidural anesthesia or analgesia is encouraged. And post-op, no Rouse tube, no drains. The urinary catheter is removed quickly. And one of the things I do personally is when I come in the next morning, my physiotherapist would have already put the patient sitting on a chair or at the edge of the bed. And then they already started drinking right after surgery, 6 hours. They already started having their first glass of clear fluids or nourishing fluids. And next day, we make sure they get at least 1 liter of fluid. So we don't give too much of IV fluids. And even on the first day after they sit up, the physiotherapist actually mobilize the patient. So early feeding and getting their guts to function quickly is some of the things that we would do. And then, of course, pain management is multimodal, and we don't use opioid at all. So no Pethidine, no even tramadol, which causes a bit of nausea. We try not to use them. We try to use COX-2s or epidurals for these patients. Yeah, I think the complication is exactly the same as open. So leak rates, bowel surgery has got leak rate, can be anything between 4 to 7% if you're dealing with rectum or post-neoadjuvant, like post-neo chemotherapy and radiotherapy. So leaks do happen. I'll be honest, the more we do, we will see leak in this one, whether we're doing laparoscopic or open. In laparoscopic, we have seen videos of people with the trocar injuries, where they put the trocar and sometimes they hit into a major vessel or hit into a bowel, like small bowel, and then we need to go and repair that. So these are some of the risk factors of surgery, any surgery, but a little bit more, maybe the trocar injuries, if you're not careful, that can happen. Yeah. For robotic, really it's the fourth arm, or that's what they call it, the fourth arm. You don't need an assistance, so you do everything in the console yourself, right? The fourth arm helps you. Now, we all know that robotics started with the prostate surgery in the pelvis. Now, that's where it's best seen the benefits. And for us as colorectal surgeon, again, the rectum. So when we work in the rectum, it is best when we're going to try to go behind the mesorectum. When I do laparoscopic, sometimes I struggle, especially in the male patient, and the robot helps that very well, getting it really low down. Your structures are beautiful. And then secondly, suturing. Suturing is much better with the robot because the endo wrist, the movement is much better compared to trying to do laparoscopic suturing. So work in the pelvis is really good with the robot. Of course, robot, the initial cost the hospital puts in is much higher, but if you have the volume, definitely the robot is beneficial. Some of the complications that I've had and doing laparoscopic surgery, like I remember early on when I was doing, while mobilizing the sigmoid and the rectum, I cut the ureter. But I think in everything, if your mind is alert and you recognize the complication, then you know what to do next. So immediately, my urology colleague was called in. We stented the ureter and we laparoscopically sutured the ureter. Now, that's one of the complications. So it's always having you're aware of the structures, and this was a difficult case with the previous diverticulitis, so due to adhesions. Another time, I was going along the aorta and to get the IMA, the inferior mesenteric artery, and I cut into the small bowel, which was lying next to it. So again, laparoscopically, we put a few sutures on that. I've never had a major bleeding. I've had colleagues who've had quite a lot of bleeding, trocar injury into the ilia. In those cases, we've had to go in and open and go and repair the vessel and then progress with the surgery. So personally, my major two have been this ureteric and of course the bowel that are injured during that. Other than that, leak rates, that's post-op day 5, day 7. So then we have to going back, wash out, resuture, or bring out as a Hartmann's or give an ileostomy. So those are some of the things that I've seen. Yeah. In our setting, so for elective surgeries, for example, hernia and things like that, patients have delayed. They have delayed because they don't want to go into the hospital. Now, when it came to cancer and all that, of course, you can't delay the surgery. So what has happened is they have to do a PCR test, even if they are vaccinated or not vaccinated in our center. So they do a PCR test 2 days before. And when they come in, other than that, there's nothing new else that we have except for the PCR test. Of course, the doctors are a bit more careful. So because I'm doing laparoscopic surgery, I use an N95 mask and a face shield, which I never used before. I used a face shield and a normal mask, but now I'm using an N95. My anesthetist used an N95 and a face shield while intubation. In the US, and which I follow personally when the cases are very high in Malaysia, during intubation, I do not go into OT. I wait outside OT, even though they're PCR negative. And after intubation, then we go in. And so in between cases, we also give a slightly longer period for the air circulation and the HEPA filter to clear up. This is just keeping all the staff in OT safer. For patients, I recommend they take single rooms because the next patient next to you, even though they're PCR negative, we know from data that sometimes some people have become positive later part, and then there's been crossed. But otherwise, yeah, those are the only changes that there. And of course, quicker discharge. I think ERA's protocol has become a major thing. I think you have to find where your passion lies. Surgery is art and science. I think it's a mixture of both. Like I said, when I first did medicine, I thought I'll do gynecology or become a general physician. I remember in Manipal, I bought my Harrison's, the big one in final year, and I was keeping that free, I'll do that. But and I hated surgery. You know, I hated blood. I didn't like going to OT. But somehow it grew on me. And now if you ask me, I think surgery is so simple to me, as long as you understand the anatomy. I mean, you can cut whatever you want to cut as long as you know where you're cutting. And then things that you need to throw off, like the breast and things like that, you just remove and take away the organ, thyroid, whatever it is. Things that you need to join back, like the bowel, the bladder, the ureter, the common bile duct, you just have to switch them back into anatomy. So there's very simple principles for me, except you need to know the anatomy around. So I think for these young surgeons, do explore. Like in Malaysia, one of the things we get is after our housemanship, we actually have 3 years before we can join a specialty. So people do jump around different specialties, what gels with them best. Because I know people have done surgery and they've never worked as a surgeon for the rest of their life. They've gone to become insurance company medical directors and stuff like that. And so you don't want to regret getting into a field. You will just, when you go to that department, you will know that whether it's something that gels with you. And for me, I think it's become second nature. I am glad, even though I found surgery later in life, I did surgery much later. Today, I don't think I can do anything else.